A 60-year-old male came in casualty with a complete heart block. On his lab finding, potassium was found to be 6. The medicine resident who is handling the case having the doubt what is the etiology of this hyperkalemia, and he have told he was searching the etiology one by one as given in the Harrison table. The topic of discussion is related to that hyperkalemia and the casualty. What you are going to handle. It is more of a practical, real-time, ground level management, case management discussion rather than the MCQ purpose one. Whenever the potassium is high, grossly, even if you take Harrison tabular column of hyperkalemia, the cause is given under 3 categories. 1. Increased intake of potassium. Very, very rare. If the kidney is functioning, kidney will take care of the potassium. Increased intake, very, very rare. Second one, transcellular shift. Unless there is a gross damage to the muscle or the red blood cells, the hemolysis, or any particular transcellular shift factor is there, this part is also bit rare. Third one, decreased excretion, where kidneys are being involved. More of kidney failure, and this is what you are going to encounter more commonly. Even in the decreased excretion part, any RAS inhibitor, what is RAS? The renin angiotensin aldosterone system inhibitor at any level if these are involved. So this is gross description. Before that, always rule out laboratory error, which is more common because of the hemolysis and all. So whenever you see high potassium, look at other parameters. If only potassium is high and patient symptoms is not matching, unlikely it is the actual patient's report. It might be a lab error or pseudo hyperkalemia. Yes, this part is done. After this lab error is ruled out, the most common condition you are going to encounter clinically is chronic kidney disease or any kind of renal dysfunction. Well, all renal dysfunction will have hyperkalemia? No, mostly advanced renal dysfunction. From the history you will get it. Suppose a patient is having, let us say, creatinine is 2 but presents with potassium of 7. There is something which is disproportionate. So what could be the etiology? Do you have to look for TTKG and all, or any other syndrome that Harrison have described? No. You have to just look for the drugs which block the RAS inhibitor, renin angiotensin aldosterone inhibitors. The terms look probably a bit technical for a medicine resident who are starting the career, that is first year. It is nothing but the BP medication, telmisartan, losartan, enalapril, lamipril, even for example aldosterone, which might be hiding behind a diuretic. Which diuretic? Torsemide, the common brand name JB Ditor. Along with that, plus might be there. Brand name I am saying, Ditor plus. That plus part is the one which is having a component which blocks the aldosterone. So clinically, it is almost always the kidney dysfunction or super added drugs. Which drugs? Technically RAS inhibitors. At the history level, you have to ask which drug the patient is taking for hypertension. Any sartan group, telmisartan, losartan, asilsartan, whatever it is. Renin inhibitor, aliscarin, any kind of renin inhibitor. Enalapril, ramipril, any pril group. Spironolactone, aldactone, finrenone, any aldosterone blockers. The new drugs, whichever is upcoming, whichever blocks this RAS pathway, is going to raise the potassium. Okay. And apart from that, any other possible causes? NSAID, diclofenac, non-steroidal anti-inflammatory drugs will impact the kidney, thereby it might raise the potassium. So whenever there is a hyperkalemia, focus on the history and don't miss the drug history, which drug the patient is having. So as I told in the initial part, that 60-year-old with heart block, the student was more interested in calculating for Liddle syndrome and TTKG type rather than simply asking the patient what drug the patient was on for hypertension. The patient, for some other ailment, he was taking Ditor plus. The plus is the one which lead to the hyperkalemia. So this is what you are going to encounter clinically. It is always kidney and always the drugs which might cause. Another major clue is the age of the patient. The syndromes, the tubular syndromes are bit rare. Probably age group might be under 20 to 40 years of age. As per the age, try to make the DD. Don't always follow the Harrison table. Harrison give the table as a whole summary. Yes, etiology can be anything, but at the casualty level, you are going to handle only two. On the background, if the patient is diabetic, again the RAS blocker. Hyporeninemic hypoaldosteronism. Renin is low, aldosterone is low, that is why diabetic patients are hyperkalemic. Another, because in India diabetes is most common, that is what you're going to encounter. So in this short summary of discussion, to conclude, just remember three things. Ask the history, look for renal dysfunction, ask the drugs the patient is on. Many times patient might not be aware, he might have went for some other ailment, let us take abdominal pain. BP in the primary clinic might be high, they might have given Telma or enalapril or any group that blocks ROS. So always ask the drug history in the past 1 week or diabetes. Kidney, drugs, and diabetes. This forms almost all cases of hyperkalemia that you are going to encounter in casualty. We can say up to 99%. Or if any resident is seeing this video, you can follow your next 1 year or during your MD curriculum. How many of hyperkalemia cases which are not of this etiology, you can try to find out and you can just number it with your fingers only. The cases are that rare because this is the most common. And whenever a patient old age presents with complete heart block, most likely the patient might be on some antihypertensive drugs only. Bye bye. This is the info in this video. Always ask the history, drugs, look for kidney, and always look for diabetes. Bye bye.